Hello everyone, I'm Dr. Forouzanian coming to you from my new medical YouTube channel. As you may know, I'm a doctor in a country that YouTube and many other social medias are restricted in it. So my videos cannot spread out as much as I want because of the limitations that the government is doing in social medias. So I hope that I can spread my videos in English all over the world, in other countries, in any other English speaker countries. So I'm not great in English, but I try to share my knowledge, to share my experience to medical students, nurses, and any other person who is working in healthcare system. So let's start with one of the cases that I had a few weeks ago. 23-year-old man comes to emergency department with severe abdominal pain, actually epigastric pain, and nausea and vomiting. So let's start. He had fighting 3 days ago, and he had bad body pain. So he came to a clinic, and the doctor prescribed piroxicam for him. He himself used diclofenac and acetaminophen because he had still pain. After that, as he saw that he had still pain, he went to a doctor, and doctor prescribed ketorolac and metocarmamol for him again. He did not receive any IV fluid. I mean, he had not any, the doctor didn't prescribe serum therapy for him. So after that, although his pain got less, but epigastric pain and nausea and vomiting starts to be dominant. So he came to emergency department 3 days after contusion with epigastric pain, nausea and vomiting. So we asked about his symptoms and we tried to find something. As we examined his abdomen, he had moderate to severe epigastric tenderness. He was aware, he was oriented to the place, to the time, and to person. He was ill, but he was not toxic. He was not pale, he was not icteric, and nothing else. So let's talk about differentiated diagnosis. Think, which differentiated diagnosis do you think that may be suitable for this case? Okay, let's start. He has severe epigastric tenderness or moderate severe epigastric tenderness, and he used NSAIDs, I mean non-steroid anti-inflammatory drugs that may harm stomach. They may cause peptic ulcer. They may cause perforated peptic ulcer. So diclofenac, piroxicam, ketorolac, all are from NSAID category. So they can cause PUD, peptic ulcer disease, or even in this case, they may cause perforated peptic ulcer disease. So this is one of the differentiated diagnoses. Let's talk about another one. He is a man, he is a person under 30, I mean he's 23-year-old that has been came with abdominal pain and nausea and vomiting. It is rational if you think about DKA, diabetic ketoacidosis. He had an stress, physical or mental, a few days ago, and he got worse and worse, and his chief complaints are nausea, vomiting, and abdominal pain. So the correct answer may be DKA. Okay, let's talk about another differentiated diagnosis. Another one is pancreatitis. Why? Because he has severe epigastric pain and nausea and vomiting. So this case can be, the diagnosis of this case can be, maybe actually, pancreatitis. We are working in emergency department, and this case is a person that couldn't solve his problem in clinic. So he has been came to emergency department. So we have to think about life-threatening or severe disease and diagnosis. So let's talk about another DDX. Electrolyte imbalance. For example, he is a person that used NSAID, piroxicam, ketorolac, diclofenac, and or many other drugs maybe, and he did not receive enough water, and he couldn't throw away waste products from the kidney by urine. Why? Because these drugs may affect the urinary output and cause AKI, I mean acute kidney injury or acute kidney disease. Do you think about any other differentiated diagnosis? If yes, please comment it for us. So, the most probable differentiated diagnosis, actually the most probable life-threatening and critical differentiated diagnoses that came to my mind are these four. And I'm going to rule out them by asking paraclinic, I mean lab data or imaging, laboratory studies or imaging or any other things. So let's start. Laboratory. I ask CBC, I mean complete blood, C is what? Complete blood cells for this patient. Actually, this patient had not fever. I forgot to say he has not fever, because maybe you think he may have cholangitis because of pancreatitis, but no, he has not fever and he's not toxic. And also you may think about biliary click or any other problem from biliary system, but we have to say that he has not right upper quadrant tenderness. But we think about biliary system disorders in back of our mind. So CBC, UN or urea, creatinine, sodium, potassium, amylase, and actually lipase. I'm so sorry because of my pronunciation, because I'm not a native Englishman, and as I told you, I decided to share them in my mother language, but the YouTube is restricted, so I cannot share them in Persian because my countrymen cannot see my videos because of restrictions as much as I want. So I prefer to share my experiences, to share my cases in English, so all people in all over the world can see my video if they want. Okay. Lipase may be a good choice. And because I was thinking about DKA, I ask VBG or ABG from laboratory. I'm asking them. So, about imaging, what do you think is necessary for this case? Actually, because you are thinking about perforated peptic ulcer disease. So, we need chest X-ray, actually upright, because you can see the air fluid level under the diaphragm. If the stomach was perforated, if the gastric was perforated, so ultrasonography is useful if we think about pancreatitis, and actually CT scan is another option, but because of radiation, I prefer not to ask CT scan yet, and I think chest X-ray and ultrasonography is enough. And the other one, I can ask endoscopy in order to evaluate PUD, but the patient has not, the vomiting of patient is not bloody, and I prefer to rule out these diagnoses, these differential diagnoses at first, and then if I rule out all of them and the PUD was the only probable diagnosis that was rest, so then I think about endoscopy in next days, because it is an invasive way, and I prefer not to do it for all patients. I'm going to find the most eligible patient to ask endoscopy. So, okay, I ask laboratory and imaging, and I'm waiting for the result. But what should I do? What should I do till the results come? It lasts 2 hours to lab data get ready. So till then, but actually UA and urine analysis and blood sugar are good choices, I think. Especially we can do it by glucometer at the same time. So I can rule out DKA immediately, but we have to know that DKA may happen in about 18% of people in euglycemic condition. But for this case, I think if the BS was normal, so I would be sure that this case is not DKA. So I'm waiting for the result of laboratory and imaging. Let's talk about drug.